So, as you all know, hospitals have risk management strategies in place to help prevent the spread of infection. So, there's standard precautions which affect all patients, and so that's just like washing your hands, disinfecting equipment, like everything that you would normally do in a hospital. And then there's isolation precautions, which they use if a patient is known to have or suspected of having a highly infectious pathogen that can be transmitted. Despite standard precautions. And so if they're put on isolation precautions, they're put in a single person room. The healthcare workers have to wear protective equipment depending on what the pathogen is. They'll either wear a mask or a gown and gloves. And they're also not able to leave unless it's medically necessary, so like to be taken for an x-ray or something like that. And so these isolation precautions have been found effective at controlling the spread of infection, but they're not the best because they've been found that they have a lot of these adverse effects. A lot of studies are coming out that they have the adverse effects, as you can see. And so the committee that actually designs the precautions is called the Healthcare Infection Control Practices Advisory Committee. And so what they do is they are the ones who say, like, you have to follow X, Y, and Z protocol. And within their actual guidelines, it says, when transmission-based precautions are indicated, efforts must be made to counteract possible adverse effects on patients, such as anxiety, depression, and other mood disturbances, perceptions on stigma, reduced contact with clinical staff, and increases in preventable adverse effects such as falls and pressure ulcers to improve patient acceptance and adherence by healthcare workers. So that being said, it's known that these detrimental effects occur, but there's little literature on ways to alleviate the side effects. And so one way to reduce the side effects is to remove the causes. So spend more time with the patients, interact with them, get them out of bed, remove the negative stigma associated with being on isolation. So in this way, physical therapy can have a big impact, and because we spend a relatively long time with the patients, we really interact with them, we get them out of bed, we like help prevent the effects of immobility. And so we can really do a lot to help prevent this, but the patients have to be willing to participate. Because if they're not participating, then we're just further neglecting them and they're not really getting any benefit. So my question when I was working with them in the acute care setting was if the patients would be more likely to work with us because they're feeling neglected, they want that social interaction, they want like someone to like get them out of bed, or if they're like feeling the adverse effects and they're more depressed and more anxious, and they're less likely to participate, especially if they're stuck in like their small rooms, they can't get out. So the purpose of my study was to identify if the isolation precautions affect patients' participation in physical therapy. And so this is really important for PTs to understand, because if they know how their patients are affected by the isolation precautions, then they can tailor their treatments, and that way their patients get the best functional goals and improvements, and you can help really make an impact to prevent these detrimental effects of isolation. So my case description, so I chose 3 patients that were on isolation, and I chose 3 patients that were not under isolation that were like had respective conditions or characteristics. So if one had COPD, I chose another with COPD, or if one was like really anxious and depressed, I chose another that was anxious and depressed. The one thing that I thought was really important was that I only included the patients that were able to ambulate independently with MINA or with or without an assistive device, because the patients who were like bedbound may not experience the same effects as like being like isolated in their room and not being able to leave. So all 6 of the patients were able to ambulate independently or with MINA assist. And then the outcome measures I used to measure this was the Pittsburgh Rehabilitation Participation Scale. And so that was a 6-point Likert scale. It was a 0 to 5 rating on how I felt that they participated. So it was designed to be from the therapist's observation. And then I made a modified one, and I gave it to the patients to rate how they thought that they participated. It wasn't how the outcome measure was designed. I just wanted to get some more information. And then I also did the Hopkins Rehabilitation Engagement Rating Scale. And so that really looked at like the different effects that there are like on participation, I guess you could say. So it's like the patient's attitude towards therapy, their level of understanding that they need therapy, their need for verbal prompts to participate, their level of like active participation, were they interested in future sessions, were they just doing it because we were there and we made them, and their willingness to attend. And so the last thing I did was surveyed all the patients and asked them if they believed that the precautions impacted their PT. Were they more likely to help work with us, less likely, what they thought about it, and overall if they thought PT was beneficial to them. So outcomes, both the Pittsburgh Rehab Scale and the Hopkins Scale found that the patients in isolation participated less than those who were not, but the results were still not statistically significant given that there were only 6 patients in the study. Interestingly, the patients in isolation reported themselves lower than I gave them as far as participation, and the ones who were not in isolation reported themselves higher. And so I tried to figure out why this occurred, and the one hypothesis I came up with was actually the result of a limitation, so the subjectivity of the outcome measures. And so a lot of the patients, when they were asked to rate themselves, really focused on their performance as opposed to their participation, so like how well they performed as opposed to how willing they were to perform. So I think the patients in isolation really, they never felt like they had accomplished as much because like we would ask them to walk because we were working, the patient population was, we weren't working on bed mobility or like anything like that. They were all able to get up, so we're working on endurance. But then after they did like a few laps to the door, they'd be done. And then as opposed to like the people who could get out of their room and like take a lap around the nurse's station or something, I think they felt a lot more like they achieved something. They had like reached a goal. And so that being said, the most consistent trend I observed was all 3 patients in the isolation surveys reported that they felt the precautions limited their ability to improve their endurance and deterred them from ambulating to fatigue. And so some of the patients still felt that PT was valuable, but others felt it was unnecessary because they were already able to ambulate without the PT's assistance in their rooms. Even though we were working on endurance, which they wouldn't have done by themselves, they didn't focus on that. So once I knew participation was kind of something we needed to focus on and PTs would need to work on, I did a lit review and I found this model, which it's kind of like it's an illustration of a subconscious like decision-making model that a patient would go through to decide like if they're actually going to participate. And in the top left, it talks about awareness of deficits and perceived treatment of benefits and the perceived need. And that was definitely the biggest barrier that I found within the patient population, was that they didn't feel that PT was really benefiting them or that they needed it. So it was really important that I educated them that they needed to work on their endurance and like all the benefits of PT and the risks of immobility, as well as what I had found about isolation precautions. So that was really important. And then also in my lit review, I found that PT and therapist communication and rapport was one of the biggest factors for patient satisfaction and patient compliance with the rehab program. So just things to keep in mind when working with patients. So limitations within the study. So just given the nature, it's a case study in an acute care setting, so it was a small sample size, and we had a limited number of PT sessions. Like I said before, the subjective outcome measures, especially with the self-rated, the patients focused on their performance rather than their actual participation. Unknown adverse effects, so I don't know, wasn't able to like monitor them 24/7 to see if they actually did get decreased time spent with healthcare workers. And I didn't take a pre or post study of like, did their anxiety or depression change over time? And then lastly, the experimental and control groups were not the same before and after. So I didn't realize this till after doing like a secondary analysis that all 3 of the patients in the control groups had a prior diagnosis of anxiety and depression, as opposed to only 1 in the experimental group. So had they been equal from the beginning, there may have been a bigger change. Like the control group, if they weren't already depressed, they may have been more likely to participate, and so there may have been a bigger change between the groups. So in conclusion, PT can be a really powerful tool in like minimizing these adverse effects for this patient population. I also just wanted to make people aware that these events are occurring, because I didn't know it until working there and like doing more research. But yeah, this information should just challenge you to recognize their vulnerability and really promote their participation in PT. Any questions?
You have question. So what did you learn from that?
That was the question we joked about. Everyone's like, "Oh, what did you learn? Reflect on that." I'm gonna reflect. I know. Thank you. I didn't know that patients under isolation had all of these adverse effects. I just kind of like, when we had so many patients at Inovan over the winter that were under isolation with the flu. And so I kind of was like, wonder how this is affecting. And I didn't know if it was because they were sicker and that's why they were, or if there was something more to it. So I started doing some research and I saw that there was already a lot to support that isolation was negatively impacting them. And so then I went further to see, but there was nothing about PT in isolation. So the need for more research, that's what I learned. Larger controlled trial. Anyone else?
Did you see any change in the patients?
You mean like my outcome? Yeah.
Did you see the ones who were in isolation actually, did they improve over time with treatment?
Oh yeah, they did. And especially one, I had a COPD patient. He was so adamant about he needed to walk to improve his endurance, and he was on isolation, but he was able to do a lot more. But he was one of the ones who was like really like, this is limiting me. I need to be able to walk further. So like we'd have to like, that was my impression. But no, he was able to do a lot more, and I definitely saw progress. We just had to really educate, like, this is like 50 feet to your door, and if you do this, it's the same as walking around the nurse's station. So, yes. Mm-hmm.
Any more? No?
No.
All right.